Well, I think it's my turn, and very briefly, I would like to discuss cytokines as possible therapeutic targets in macrophage activation syndrome presenting as a complication of systemic juvenile idiopathic arthritis. And my main focus will be, in fact, interferon-gamma. So just to remind some of you here, in pediatric rheumatology, the term macrophage activation syndrome refers to a clinical phenomenon caused by excessive activation and expansion of T cells and well-differentiated non-neoplastic macrophages. Most importantly, these macrophages exhibit hemophagocytic activity. The expansion of these cells leads to a massive systemic inflammatory response associated with cytopenias, liver dysfunction, coagulopathy consistent with disseminated intravascular coagulation, and very, very high serum levels of ferritin. It's a potentially life-threatening complication of systemic JIA, and the reported mortality rates still reach 20% in the pediatric literature. If you look at the adult literature in Still's disease in particular, it's up to 50%, in fact. Now, as you know, it has been reported in association with almost any rheumatic disease, but strikingly, by far, most common in systemic juvenile idiopathic arthritis. If you look at the reported cases, about 80% of them actually occurred in systemic juvenile idiopathic arthritis. Conversely, if you look at all patients with systemic juvenile idiopathic arthritis, about 10-15% of them develop overt full-blown macrophage activation syndrome. But there is also quite a bit of evidence suggesting that in mild subclinical form, it occurs in as many as 30-50% of patients with active systemic disease. And in fact, as pediatric rheumatologists, we should be able to identify those patients with subclinical MAS at the early stages of this syndrome before it progresses to its full-blown life-threatening stage. Now, in terms of its pathophysiology, first of all, I will start with a brief description of the histopathology of inflammatory lesions in MAS. They're actually quite distinctive, and in fact, I was listening, Scott, to your presentation, very reminiscent to what you described in your population. The inflammatory infiltrate consists almost exclusively of histiocytes and T cells, and if you look at the T cells, it's predominantly cytotoxic CD8 cells. All these cells produce massive amount of cytokines, creating a cytokine storm. And in fact, many clinical features of MAS could be directly linked to this cytokine storm. A couple of examples. Here we are looking at a liver biopsy from a patient with macrophage activation syndrome. If you look at the panel here, massive periportal mononuclear cell infiltration, mainly histiocytes and T cells. Many of these macrophages, histiocytes, in fact, are highly activated with a sort of plum cytoplasm. Many of them exhibit hemophagocytic activity. And in addition to being hemophagocytic, these macrophages also produce quite a bit of pro-inflammatory cytokines, including TNF-alpha and IL-6 in this example. That's a paper that was just mentioned, the paper from Japan, showing that in patients with macrophage activation syndrome, these macrophages seem to be the main source of IL-10. I don't know how to go back. Sorry, I made a mistake. But anyway, the point of those paper was that they looked at different tissues, and at least in that particular patient population, hemophagocytic macrophages in the bone marrow looked like they were the main producers of IL-18. I mentioned that another prominent cell population in inflammatory lesions, it's actually T cells. And if you look at the T cells, there is a marked predominance of cytotoxic CD8 cells over CD8 cells. This is an example of bone marrow staining of one of my patients with macrophage activation syndrome. And these cells produce quite a bit of interferon-gamma. Again, I'm going back to this paper published by Karine Waters some years ago, and again showing massive CD8 infiltration in the liver, and these CD8 cells produce massive amounts of interferon-gamma. And as you know, in several animal models of HLH, a disease that is very, very similar to MAS. These interferon-gamma producing cytotoxic CD8 cells have been implicated as the key players. Elimination of either CD8 cells or neutralization of interferon-gamma, in fact, completely prevents the development of the HLH phenotype in these animals. So based on all these observations, we believe that perhaps what's happening in MAS is that it starts with this uncontrolled expansion of cytotoxic CD8 cells. These cells produce massive amounts of pro-inflammatory cytokines, most notably interferon gamma, and also there is some evidence that GM-CSF may be produced by these cells as well. Chronic stimulation of monocytes and macrophages with these cytokines leads to a massive expansion of macrophages. They acquire a rather bizarre phenotype. Many of them become hemophagocytic, but most importantly, they secrete massive amounts of pro-inflammatory cytokines, including TNF-alpha, IL-6, IL-1, IL-18. And certainly some of these cytokines have the ability to further stimulate cytotoxic CD8 cells and interferon gamma production, and perhaps the ability of IL-18 to stimulate CD8 cells to produce interferon gamma does play a major role in this loop. So in other words, we have this vicious circle, and this vicious circle is associated with this escalating production of cytokines. So a cytokine storm, based on that, targeting cytokines might be a very, very attractive therapeutic strategy. The question is what to target. The first obvious targets were IL-6 and IL-1. As you know, agents blocking IL-1 and IL-6 are highly effective in systemic juvenile idiopathic arthritis. And since many episodes of MAS are often triggered by systemic JIA flare, it's reasonable to expect at least some response to this inhibition due to a better control of the underlying disease. Unfortunately, that did not happen to be the case. If you look at the results of the phase 3 clinical trials of tocilizumab and canakinumab in systemic juvenile idiopathic arthritis, overall, for patients treated with tocilizumab and canakinumab, the MAS risk was certainly not increased, but there was no full protection even in patients whose underlying systemic JIA was very well controlled, suggesting that perhaps IL-1 beta and IL-6 are not the key players in the pathophysiology of macrophage activation syndrome. The story with anakinra is a bit different. Certainly, there are many convincing reports where it was helpful, although Peter, correct me if I'm wrong, in your study, when you sort of looked at more systemic use of anakinra in patients with systemic juvenile idiopathic arthritis, you actually did observe several patients who developed MAS while being treated with anakinra, although I believe that at least there was at least one case where increasing the dose was helpful.
Yeah, most of them. Mm-hmm. Most of them increased the dose. Mm-hmm.
Right. So I think the consensus is that certainly anakinra may be helpful, at least in some of the patients. And the question is, are we dealing with some kind of a heterogeneity, and there is only a subgroup of patients who would show response to anakinra? Or another possibility is that unlike canakinumab, anakinra also blocks the activity of IL-1 alpha. So the question is whether pyroptosis and release of IL-1 alpha in MAS plays a major role, and perhaps that's where anakinra might have some advantages compared to canakinumab. But anyway, coming back to this cartoon, so far we've been talking about mainly the cytokines that kind of more downstream, if you wish, in this scheme. So what about those cytokines that are a bit more upstream? And certainly one of them is interferon gamma. Now, interestingly, interferon gamma does not appear to play a central role in the pathogenesis of systemic juvenile idiopathic arthritis without MAS. If you look at now quite a few gene expression studies, in fact, none of them could show any evidence of interferon gamma activity, no evidence of interferon gamma induced signature in the peripheral circulation, at least. Scott will ask me a question about what about the tissues, and actually the same true is in the tissues. If you look at synovial tissues, and if you look particularly at the expression of the interferon-induced chemokines, actually there is a marked difference between patients with systemic juvenile idiopathic arthritis versus other subtypes of JIA. Just as an example, we're looking at IP10. Remember, this is the interferon-induced signaling. When interferon gamma binds its receptor, it eventually leads to phosphorylation of STAT1. Phosphorylated STAT1 eventually moves to the nucleus and activates a number of genes that are important in that cascade. And we, in fact, can look at the interferon signaling through different ways. First of all, we can look at the percentage of cells with phosphorylated STAT1. And we also can measure the cytokines sort of as an interferon-induced signature. And my point is that if you look at these chemokines in patients with systemic JIA in the synovial tissues, in the joints, they're much lower compared to patients with other subtypes of JIA, suggesting that perhaps in the SJIA itself, this is not a major player at all. However, things may look different in patients with macrophage activation syndrome. In fact, when we start seeing emergence of some clinical features of MAS, in fact, we start seeing phosphorylated STAT in monocytes, freshly isolated monocytes in these patients. To explore this phenomenon a little bit better, in collaboration with Fabrizio De Benedetti and Angelo Ravelli, we sort of looked at the relationship between MAS features and interferon-induced signature. And we assessed levels of interferon-gamma itself, as well as interferon-gamma-induced chemokines, as well as other cytokines in patients with active systemic JIA without MAS features, SJIA with MAS features, and patients with inactive SJIA. And those levels were correlated with typical laboratory features of MAS. Just a few examples from this study. I think that's a wrong presentation, sorry, but sort of what I'm trying to show you here, we are looking at the correlation between the levels of interferon gamma and the chemokines with ferritin, which is, we sort of use it as a biomarker of macrophage activation syndrome. And in this particular plot, we distinguished patients with full-blown macrophage activation syndromes versus those with active systemic juvenile idiopathic arthritis. So as you see, the sort of red triangles seem to be higher than the black ones, again suggesting that we see higher levels of interferon gamma and the chemokines in patients with MAS. But another interesting feature is that if you look at the correlation between for example, CXCL10 and ferritin, it's remarkably high for patients with MAS, but there is absolutely no correlation for patients who don't have any features of MAS. And sort of we certainly see it as evidence suggesting a causal relationship between interferon and macrophage activation syndrome. That's another way to look at the data. So here we are looking at the levels of interferon gamma and interferon-induced chemokines in patients with active MAS or active systemic juvenile idiopathic arthritis without any evidence of MAS. And we are dealing with paired samples. And you see that sort of this trend is pretty much obvious everywhere. In contrast, I think I'm stuck. Yes. So in contrast, when we did the same type of analysis with other cytokines, and in this example, we are looking at IL-6 and TNF-alpha, there is nothing even remotely similar. Again, suggesting sort of what we observe is very, very specific to interferon gamma. That's actually Vikram. I don't think I'm breaking HIPAA regulations here. So as you know, Vikram has been having a very difficult time. He has a very, very challenging disease. In this example, we are looking at 4 major flares over approximately a 1-year period, despite the fact that we are using extremely high doses of canakinumab, steroids, cyclosporin. But I would like to draw your attention to a few things in this slide. So the first 2 flares were clearly consistent with macrophage activation syndrome. Very high ferritin, cytopenias, liver dysfunction. Then he was managed with quite a bit of steroids and cyclosporin, was doing relatively well. So that period of time was relatively quiet. And then more recently, we had two more major flares that were actually consistent more with the flare of underlying SJIA rather than MAS. You can see that in this case, actually, ferritin didn't go up very much. In fact, instead of cytopenias, both platelet count and white blood cell count went up. He was running fever. So overall, these 2 flares were more consistent with SJIA rather than MAS. So 5 time points where we looked at his interferon-induced signaling pathway. The first 2 points were episodes of MAS. The third time point was a relatively quiet disease, and then 2 more time points when we clearly had a flare of underlying SJIA rather than MAS. And the results are shown here. So again, the first 2 time points, very high levels of interferon-induced chemokines. The third time point, a quiet disease, things looked relatively quiet. And again, when we looked at the same chemokines at the time when he had a flare of SJIA without evidence of MAS, actually we did not see much of the interferon-induced chemokines. When we looked at the same time points at STAT phosphorylation in freshly isolated monocytes, there was quite a bit of STAT phosphorylation at these 2 time points, and we did not see much evidence of STAT phosphorylation at visits 3, 4, and 5. So my final conclusion is that sort of overall in systemic juvenile idiopathic arthritis patients, we don't think the interferon plays a major role in a conventional flare of systemic juvenile idiopathic arthritis, but we certainly seeing activation of interferon-induced triggering signaling pathways that clearly parallel the emergence of clinical features of MAS, and we do think that it suggests a causal relationship. And I think it was my last slide. Thank you. So, Fabrizio?